except for the people who've never attended before, most of you know me. I'm Ed Ratner, a geriatrician at the VA and the university, and kind of a very, very long time member of MAGIC and its predecessor. And I'm going to moderate a discussion about what we just saw and heard about. And I want to introduce the two other panelists that will discuss this. Steve Atkinson, to my left, is a board-certified physician assistant specializing in geriatric internal medicine, practices in the Twin Cities area, and has been a faculty at University of Utah since the mid-90s, involved in medicine for over 30 years. A founder and co-owner of Twin Cities Physicians that services older people in nearly all levels of their care. And I'm very pleased to have collaborated with him and taken care of patients in that setting. They do a great job, and he's presented nationally and internationally for over 15 years in geriatric-related syndromes and authored several books, including those in geriatric pharmacology, dementia, business of geriatrics, and his main goal is to elevate the level of care in medicine for elders he serves. So thank you.
Thank you.
And on my right is Carrie Everson, who has 25 years experience in healthcare with expertise particularly related to assessment, care delivery, compliance, leadership, education, and quality. And she's the director of clinical care and clinical consultation for Leading Age and the president of Uvovia Senior Care Consulting. She's worked in operations in nursing homes and housing and home care, and is an educator in secondary nursing programs and teaches courses at the University of Minnesota. So thank you. What we wanted to do is follow up on the presentation regarding robotics. And in terms of approaches that we could use, I have some questions kind of for the two panelists, but also kind of for the audience. And I see this as an opportunity to think about and then maybe communicate back to the engineers and computer scientists, what problem do we want solved? Because they come from the technology, and I've worked with engineers who say, here's a technology, what problem can it solve? And I think the list of things that that team is working on represents that kind of approach. If we can say, here is the problem that we think a device of some sort can solve, that might help direct the approaches they take to that. So kind of I'll start there is, what do you, Steve, see the biggest problem that a technology such as robotics could solve in long-term care, whether it's institutional or home-based care?
Probably first and foremost, I mean, thanks. One of the first and foremost things that we were trying to at least accomplish in our practice was making sure that we could facilitate care, right? At least some sort of interaction with people. But even what I saw today, which is leaps and bounds beyond what we were using robotics for in some of the buildings that we're in, was literally, being able to engage people and maybe mitigate some sort of concern. So if that alone, right? I mean, I think everybody here, when it comes to caring for older people, really has this responsibility to keep people out of the one place we hate to see them go, and that is a hospital, right? And so if that alone could happen, and they could show this in a research type of style, I think it would just be amazing, especially considering the phone calls I take, and I'm sure many of you take, to say, wait, it's okay, let's see what we can do. Maybe get them on the phone in front of me. That technology, too, has made a big difference. But to do it in terms of robotics where they can preempt it, my goodness, can you imagine? It would just be amazing. So
let me kind of rephrase that. It's one of the things they talked about working on is the early detection by posture in the seating or movement in a kind of a monitored setting, or the wearables. So you're kind of saying, is there predictors of that if we could identify that problem, a day earlier, then we could intervene with the highest risk patients. Okay, Ari?
You know, as I was listening to the presentation, there's some fascinating applications. But I think in order to get people to use it, other than the cost, I was so glad somebody asked about the cost, because I thought, how are we going to pay for this? I think in addition to that, we have to get providers to be, or the nursing homes, to want to use it. Every time we introduce a new technology into nursing homes or assisted living communities, it always is kind of, we have to drag people along because there are all sorts of barriers or perceived barriers. So I think focusing on, and I were talking about this, she had a lot of great applications, but when we're talking about problem solving for the individual nursing home, we really have to look at a couple of things, in my opinion. One, staffing issues. Staff are burnt out if they've got them. And if they don't have them, then they're even more burnt out, and we are having to reduce what we're doing for care because we have to change to necessary only care, which is an interesting concept. Then once we do that, we also have a regulatory burden that we have to meet in long-term care, and the regulatory burden is huge. So while we want to be able to provide good care and we want our residents to have good care, we spend a lot of time dotting I's and crossing T's so that we don't receive regulatory citations which come with associated fines. So if we can kind of direct or provide those robots for some activities that truly are engaging to the resident, but also help reduce staff burnout, staff fatigue, and the regulatory burden, that's what's probably going to be key to get us to have communities engage in utilizing this type of technology.
From the audience, other thoughts in terms of where would you kind of apply technology, and what problem, the outcome do you see as being really key? Other thoughts?
Something that just popped into my mind. I don't know how, depending on the resident, but a lot of times they struggle with the people who need like a one-to-one, like just some distraction. I don't know if, depending on the patient, even just having that robot there to give it some distraction, that eases the burden for staff a lot.
Okay, so the one-to-one, and how many of you work in hospitals at all? Maybe. Okay, so so it's a minority, but I know at the VA hospital, this whole problem of the patients with behavioral problems who come in the hospital, and we can't discharge them because no facility has the staff and the wherewithal to accept somebody with new or much worsened behavioral problems. So we want to prevent those hospitalizations, but some of those patients come from home and then they're kind of stuck in the hospital. One-to-ones are what you end up with, but how many of you work in nursing homes that won't accept anyone who has a one-to-one in the hospital? And that's kind of the policy. Okay, so that's a common thing. So they can't leave until they don't have a one-to-one, but they need a one-to-one in the hospital because it's such an unsafe, relatively unsupervised setting that somebody's got to sit there all the time. So I think that idea, and that isn't kind of that isn't a quality of life, but that's a need for something to basically distract somebody from trying to get out of bed or pull out their IV. And so somebody like substitute for a family that ideally they would be sitting there.
Well, and that's a great, sorry, I should talk louder. That's a great application too, because one of the other things that's trickling down right now is we're finding that hospital decompression is a real need because we have people backed up in the hospital. The front door is backed up, we can't get people in. The back door is backed up, we can't get people out. And when we have a lot of the reasons that long-term care communities aren't taking some of these residents is sometimes it's the medically complex stuff, but more often it's the behaviorally complex individuals. So if we can find a way so that they can more easily take those residents, it's also going to stop that back up into our acute care system and hopefully help move that continuum along.
Great.
When I think about the world of robotics and how it could help us as magic, in clinicians inspired through geriatrics, it's that home base, try to keep them out of the hospital, try to keep them out of the nursing home. Really, we don't have enough beds in the nursing home, so can we use these little guys in individual homes, that medication administration, the smart pill boxes? I think we all can see that is what's really causing our patients to go into the hospital if they took too much of whatever. We don't even know what they're taking. And then also being able to do a telehealth visit. I think that's where we really know that that's what needs. They need a provider visit. They can't get to the clinic. We can't get to them. They have iPads right on their desks. That's how we can facilitate that visit. So get these little guys into homes across America. Holy cats, that could really do us.
So, and kind of for those of you working in the home setting and with caregiver, the family caregivers, the spouses typically, sometimes the children, of people with dementia, because that's kind of where the focus of this research has been. Do you see this as a tool in terms of helping the caregiver leave somebody alone so they can, not alone in the house necessarily all by themselves, but they can go in another room and they know that somebody is, or something is there. Is that the kind of thing? Go ahead.
I think it is. I'm going to stand up because I can't see you from this end. I think it is because my mom lives at home. She has to have help. She's not able to use the phone by herself. That can help her do that without me worrying about it. But it's always the cost. The problem is early detection is at home, but you focus on the problem in the nursing home where it's not early detection anymore. So that's why it's confusing sometimes because it's not where it should begin.
Yeah, so thanks, Ed. I think the big thing we need to continue to advocate for is when we have these new technologies, robotics or AI, it's not going to make things harder or more challenging either for the caregiver or for the provider groups. I mean, we had this big, beautiful, the EMR is going to make our lives a lot better. No, I mean, seriously. So imagine AI analytics saying, your mom's going to fall. Your mom's got the, if the burden's going to be higher on our caregivers and our loved ones, we got to make sure we let the engineers, let the scientists know that we really have to make sure that the burden is going to be less on everybody. And that has to be a really upfront discussion point. And if you have a little bit less burden on people, we can use the technology to help be a little bit better at home or in our facilities. I think that's the big worry I have is that we've been sold this a couple of different times. It's going to make our lives better. And, and that's what we all laughed about the EMR. But, we've got tremendous amounts of data, which is great, but it's like, I live in the EMR. I don't want to have that happen with the robotics. So now we have all our nursing and CNAs working with, oh my gosh, there's a AI alert on this problem, and we spend all this time kind of dealing with what the computers tell us we have to do now.
Alarm fatigue.
Yeah. Kind of alarm fatigue. How many of your facilities are using bed alarms? Okay, minority. And how many used to use them and said, that's not worth the trouble? Okay, so more. And I think there's a variety of things like that. We realized that the sensitivity and specificity of that system wasn't good enough. And so if it's an early detection, it needs to kind of then not burden us with then interventions in people who were, just a little bit more higher risk. We can't kind of do it more. Other thoughts regarding that?
I think if you look at the cost, the indirect and direct costs of Alzheimer's disease, just Alzheimer's disease alone, there's a substantial benefit to using technology to help caregiver burden. And so to piggyback on what you said, it's important to not get inundated with information, but it's important to try to ascertain, hey, we know based on these spatial features, based on this person's history, that this is likely to happen. And so those kinds of alerts are where people could step in and maybe prevent, if you will, something from happening that's very serious and, more importantly, problematic. I love it. Yeah. And we all live, everybody in this room probably lives to reduce antipsychotics and medicines that really can be harmful to people, right? And all I think about is my own flesh and blood, and saying, would I want to put my mother on an antipsychotic? Maybe if there were issues and I just needed to mitigate something, but if I could step in and do it well before that ever occurred, my God, I take those phone calls in a heartbeat. I literally would, saying, okay, we can prevent this, let's do it. Hannah?
I think right now with the technology the way it is, it doesn't seem like it's going to solve our staffing shortages, but where I see the benefit is the quality of life. Like, I don't know how many of you have walked into your nursing homes and felt like these people's lives are so boring, they don't have much interaction, they just sit at the nurse's station, people barely talk to them, or they watch TV all day. Like, to have someone interact with them, something interact with them more then that's great.
Wasn't it fascinating that when Dr. Khan showed us how you could input information about a person and their likes, right, their interests, and walk in and tap into that interest, right? I mean, for me, that's just fascinating. To say, hey, tell us about your history, get us that information. It's inputted into the computer, which never forgets, and walk in and engage a person. I mean, that alone speaks volumes, guys.
So I'd like to kind of highlight that and the social isolation that I think this kind of problem can solve. But in institutional settings, there's less problem with that than the people who are in homes or in settings with fewer people and less congregate activities where there, it's a critical mass. The other question is, and I kind of throw this out, is she's targeting kind of moderate to severe dementia, and I think it reflects the relationships in the nursing homes and the populations there. Thoughts about the less impaired or non-cognitively impaired now to prevent the decline by having greater social interaction, because that's actually one of those risk factors is isolation. Thoughts about that?
I think for those people that, I think in assisted living, we're seeing a lot more of that because people are in their apartments more, there's less congregate activities. But I think too, what we see in people that don't have that level of dementia is a lot of anger and a lot of irritation, especially if people can't get there right away. We get a lot of things like my call, it's been on for 30 minutes. And when you look at the report, it's been on for 4, but 4 minutes can seem like a lot of time when you're sitting there waiting for assistance. So if there are things that those robots can do to try to take care of whatever the basic thing is, I need my book, I need my chapstick, I need, a glass of water, whatever the case may be, those people are probably going to be less unhappy in our organizations. We're going to see fewer complaints. We're going to see fewer calls to the ombudsman, fewer calls to OHFC, fewer investigations, lower regulatory burden, because those individuals get very angry when they can't get the stuff they need, particularly in the last 3 years when staffing has been so very challenging.
And I couldn't agree more. I mean, I couldn't have said that better. Yes.
When we talk about, of course, the human need for interaction and activity, I find my mind going, and perhaps technology has a great role that's not discovered yet, about intergenerational programming. A lot of 4-year-olds can lead the Macarena, and we have a great need in this country for improved child care as well as elder care. Yep. I think that is a more human, to me, field of opportunity that certainly may use technology, but it's not about the cuteness of a robot, it's about a real live young person.
I agree. I like the comments about kind of that, where do we kind of move it forward, or how do we move it kind of in that before people become incapacitated with dementia. Because I think that's really where, as my head was looking through this, how do we start helping people retain their autonomy and independence by using this? So even somebody living in independent living, how do you have the robot kind of as that safety net? You remember the stove is still on. Oh, thank you. Because those are the kind of things. You leave the stove on and goodness, you are off to memory care. So how do we help use this kind of technology to really keep people doing the activities they like? Here, let's do this activity together. Let's figure out how to do it. Let's figure out how to help you go find your chapstick. I'll go with you, as opposed to just only thinking of them doing things for the person.
So kind of more a prosthetic rather than a kind of an external kind of thing to help people make it easier to do what they can't do as well. Go ahead.
I could see an application for when they're living at home. You could share it with like 7 families. So then the caregiver gets that 2-hour break to go to Walmart and just to get out of the home. because I see that a lot with caregivers. They have this fear they can never actually leave the home or go without them to leave them alone. And so knowing that they can get out at least once a week could make a difference between staying at home or being in a facility.
So what you're describing, if we want to label that, would be a respite model. So the programming would be kind of whether it's the reminiscence therapy or just some activity and monitoring, so that a caregiver can leave kind of comfortably, and maybe just take a nap, but it maybe leave the house. And I think.
And then if the robot was shared, it'd be one robot for 7 families.
Yeah, so kind of the neighborhood robot, and it goes from house to house, in that, or, I mean, house, it could be kind of the active senior. How many of you have worked in, and kind of what were active senior communities when they were built, but now are assisted living kind of places? And I've seen that in the senior housing that was built in the 80s. The people stayed until then they had to kind of adapt and have more and more care suites and on-site care, for example, so being able to substitute in that setting. Okay, so I kind of want to turn to the cost came up earlier. So, part of this is we saw that initially, and I thought, gee, they built these things, that's really cool, but then we came to realize they just buy them and program them. What do you think are the, price points that make sense with these kind of things? Because there are, for some of the applications that we've talked about, there are the robotic pets, for example, which have been studied and are efficacious in reducing angst in people who have dementia, in a variety of settings. What do you think this is worth if we were to say, figure out how to do this for X dollars, because beyond that, it's not realistic? In the back there.
Take it out of the realm of medical device and just market it as a geriatric tool. I think the restrictions drive the price up. And I think that would make it more palatable in terms of the marketplace to get it into homes. And then if it needs to be a medical device to get into facilities, then can the facilities have a billable hour for its services so that it pays for itself?
Okay. So this just, I'm working on a development of a mobility device, and I've learned over the past 2 years about this FDA-approved devices versus not. And the FDA-approved device is absolutely necessary if you're going to have any kind of insurance cover it, okay? Or if you make any medical claims about a device. But there's a lot more devices that aren't FDA approved that people just go and buy. And so an example are the sit-down scooters. Some of them are FDA approved, and there are all kind of regulations. And basically it doubles, triples the cost, because both the requirements of design as well as the costs of getting the FDA approval. So I think that the comments that we're trying to move this toward an FDA approved device, it was unclear to me kind of the extra value that would come from that versus the cost.
When I thought about the cost or the return on investment, a lot of the lists of what the robot could do currently or what it was aiming towards was, supplementing or augmenting a robust therapeutic recreational department. And so if you think of, if you were to hire a new person to staff your therapeutic rec department, that'd be a 40-hour week person. What do they make per hour plus benefits? The robot does pay off there. But I would hate, to your point, to put a robot doing bingo so then the person can go fill out the forms for CMS so they don't get, FTAG. So that's not what we want.
When she said that, I was thinking, maybe the person who is the activity doesn't call bingo then, but maybe people that need like hand-over-hand assistance.
Exactly.
The
That's
doctor
what I
or whatever
think.
they're doing, maybe that's what they could be doing instead.
Yeah.
But I agree. I wouldn't want to put people down in front of a robot and say, bye, see ya, and
Yeah,
walk
I'm
out.
gonna go fill out forms,
Right.
so I don't get an FTAG.
Okay, so we're going to wrap it up there. We have, there are some cards on the tables, and I want to tell you what those are about. Topics is the I think 6 times a year has it come out, is that right? It's our newsletter for our state association, and several other states receive that and distribute it to their members also. We're always looking for ideas for future topics that can be published. And we have the format of that, if you haven't received it in the past, is kind of a long form review article or opinion piece, but they're high quality. They take a significant amount of time to write a good article for that. So we're looking for ideas of topics. We're also looking for ideas for writers. And so if you have a topic, say, gee, I've worked on this, I'd really like it distributed, and I have something not in the can necessarily, but almost ready, put that down. And throughout the day, if you think of things that come out of the presentations. So we're going to take a break. The exhibitors are set up, and they want to meet you, and they are underwriting this conference, so it's more affordable, and we can have a nice lunch and get together. And so part of that is having them meet enough of you to justify them coming back next year. So take a break and go. And one other thing.
If I could, there's no restrictions, guys, on who can publish in topics. So if you have an interest, okay, all we'll do is edit it. That's it. So please, if you have an interest or if you have something that is you're really passionate about, please send it our way. We'll throw it through the editing process, and we'll get your name in lights, okay? All right, okay.
So, pardon? Yes. What you'll write, but also things you want to read about, or something you want to hear. So at 10 o'clock, come back. Half of you are going to come here and hear about trends in pharmacy from Haley Griffin, who I work with at the VA. She's a great talk that she's put together for that. And in the other room, we're going to hear about the future of geriatrics at the University of Minnesota, and there's some exciting changes going on there that impact the future workforce. So thanks. We'll see you back in about 10, 12 minutes. Thanks.